Hey, my name is Kimberly Keefe Smith, Dr. Keefe Smith. I'm come from the Brigham and Women's Hospital, the Center for Infertility and Reproductive Surgery. And I'm so excited to speak at this event again, this amazing event put together by Resolve New England with, of course, Caleb Blank and Emily Lindblad. Such an incredible day. So thank you for including me on this very special event. I will throughout the talk be available live as well, even though this is pre-recorded. I'll be in the chat answering questions as they go. So if anything comes up as you're hearing and listening, please feel free to put that question right directly into the chat. I'll be right there to answer. So today I'm going to be talking about eggs, all about eggs, and specifically focusing on that sort of challenging diagnosis, diminished ovarian reserve, and how we tackle that and how you can kind of think about it. So I have no disclosures. And just to kind of go over what we're going to talk about, we'll talk about just egg basics. You know, we all know that they are there in the ovary, but maybe a little bit more about number, quality. How do we assess that number? What testing do we do when you come see somebody like me as a fertility specialist to look at general number of eggs? And what does it mean to be diagnosed with lower or diminished ovarian reserve? And then we'll talk about strategies to treat infertility or difficulty conceiving with that diagnosis of diminished ovarian reserve. And as we talk about, we'll talk about supplements. Are there things that we can do to change anything? Because people with ovaries are born with all the eggs we're ever going to have. So is there anything we can do to change that? And then we'll talk very briefly at the end of more experimental therapies as to what that might look like. So just to remind you, I don't know if you've thought about this at this level, but how does a pregnancy occur? So from the ovary, we see that eggs develop, and there's this long development process that we usually think about just the menstrual cycle as that time when an egg develops and then is released. And then that egg has to travel into the tube to meet sperm, create an embryo in the tube, and then that embryo has to move into the uterus to ultimately implant. And it takes a while to do that. And so this is just to say that when you're not involving any sort of treatment that takes eggs outside of the body, like IVF, with somebody's own eggs or autologous eggs or donor egg, this is how those eggs sort of their path that they both sort of pursue within the ovary, but then also once they leave it with ovulation. So what is so special about eggs? Well, eggs, as we know, carry half the genetic material required to make a baby. So you need an egg and you need sperm. Eggs are such a precious commodity because people with ovaries are born with all their eggs they're ever going to have. In fact, the peak number of eggs is 7 months gestation. That's when it happens, when the person with the ovaries who's trying to conceive as an adult, they have the most eggs they're ever going to have when they're inside their mom's uterus at 7 months gestation. You can see here this very old study from 1970 that really looked at that total egg reserve, the eggs kind of in the deep storage of the ovary, the primordial germ cells, we call it. And what you can see is that number peaking even before birth. By the time a person with ovaries is born, their ovaries have dropped down that number of eggs from initially 6 to 7 million to around 1 million eggs. Still a lot, but a big change, even before the person even comes out into the world. And then by the time that person hits puberty, when periods start to occur and ovulation starts to happen, we're down to about 300,000 eggs, anywhere between 200 and 500, but we sort of say 300,000 eggs. And that's before an egg is even released from the ovary. And then over the course of a lifespan, if just people are not pregnant or they're not on any form of hormone that would prevent ovulation, like a birth control pill or something like that, about 300 eggs are released total from the ovary. So talk about inefficient, right? That this is all the chances that we'll ever have at pregnancy when there isn't fertility treatments involved. So they're very precious commodities. And even when people aren't ovulating. So if people had a pregnancy, or there's stretches where people aren't getting periods, they're not releasing eggs, either because they're on a medication or there's something else going on that's preventing eggs from being released, those eggs that aren't ovulated, they're not saved for later. They actually become absorbed by the body. They're thrown out, basically. So, even without ovulation, unfortunately, there's no way to preserve those eggs that are there, whether they're ovulated or not. The ovary is like a metronome. It will recruit a few hundred eggs, maybe release one, maybe not, but then throw that group of eggs away. And that happens every cycle, every month, until we're down to about 1,000 eggs around the time of menopause, when periods stop. That average age of menopause is about 50, 51, but there's a huge range of normal. So anywhere between 40 to late 50s, maybe early 60s, can be normal in terms of when folks run out of eggs. And a little bit more about these eggs, not just quantity, but also quality. What is the chance that an egg that comes out of the ovary has the chance to actually make a baby? Because when you're family building, that's what we care about. It turns out only mature eggs have that chance. So only eggs that one are released by the ovary by itself, either with ovulation without treatment, or in the setting of fertility treatment where we're getting the ovary to release the egg. That's a mature egg that's being released from the ovary. In IVF, we hope that the majority of eggs will be mature and have that capability, but it may be that there are a significant portion of eggs that don't have even the option of mixing with sperm because they're immature. Usually that's only maybe 20%, but there can be a lot of variety from person to person. And each mature egg is not a guarantee of a baby either. It has about a 2 to 12% chance of making it all the way down that road to a baby, because it has a long way to go. It has to mix with sperm, and then that embryo has to grow. And then that embryo, once it makes it into uterus, has to sort of make it all the way. So it's a long road. How do we test that general number of eggs? How do we get that snapshot in time to see where those ovaries are regarding that number of eggs? So ovarian reserve testing is the way we do that. And we have 3 different ways of doing that. 2 are blood tests, 1 is an ultrasound. And so what we do is we take this knowledge about how eggs are recruited. They go from the deep storage of the ovary, the long-term storage facility, the primordial follicle pool, and then they start to get recruited. We can start to see them on ultrasound or measure if they might be there when they start to become visible on ultrasound and they start making hormone that talks to the brain. So we actually measure that signal from the ovary to the brain, estradiol or estrogen, and we measure the signal from the brain to the ovary to grow eggs, follicle stimulating hormone, FSH. When there's a robust number of eggs in the ovary, when there's a bunch there, the brain just has to whisper to the ovary to grow eggs. So follicle stimulating hormone level is low. It's, ideally, it's going to be under 15. And even in a perfect world would be under 10. And then for estrogen levels, estradiol levels, when we measure it early in the menstrual cycle, which is when we do this FSH and estradiol level, usually ideally day 3, although it can be day 2, 3, or 4, with day 1 being first day of full flow bleeding. We want estradiol levels to also be low because, as you can see in this picture, the follicles are small early in the cycle when they're making that estradiol, when we're getting that next group of eggs that the ovary is offering up to the brain to pick from for that cycle or that month. So we want estradiol. There's no firm cutoff for estradiol on day 3, but 80 is sort of, or at least under 100 is sort of what we look for. Anti-Mullerian hormone is the other test, AMH, which has gotten a lot of press both in fertility and outside of fertility, as people thankfully are thinking more about the number of eggs, this sort of limited precious commodity that people with ovaries have. AMH can be measured at any time in the cycle. It's not cycle dependent. And it's made as those eggs move from the part where the ovary is growing them to where the brain can talk to them. So that's when the AMH is released. And we know it's more or less stable. There is some variability from draw to draw, but for the most part, it tends to be within the same grouping when we measure it. And this is a big spectrum as to what is considered normal. And we know at different ages, different things can be normal. Now, where it matters most with AMH is when we talk about fertility treatment, specifically IVF. That's where AMH matters most, because it's telling us how big a pool of eggs the ovary is offering up to the brain. And it's that pool of eggs that the brain is picking from that we grow, or we try to grow in the IVF process. So AMH is really most helpful when we're talking about IVF. And AMH also, we know the general trajectory is down over time, that it becomes undetectable, shortly before menopause, before periods stop. And so what is low? There's really, again, these are not hard, fast cutoffs, but just to give you a general idea, probably average is somewhere between 1.8 and 3, or 2 and 3. That's kind of the average, or what is reassuring, especially when we're talking about IVF. But as ovaries age, as they get over the age of 35, and then over the age of 38, and then into the 40s, it's very normal for that AMH to drop low. And under 1 or 1.1, 1.2, depending on the study you look at, that is associated with getting fewer eggs in an IVF cycle. So, maybe less than 6 eggs in an IVF cycle. So that's where we kind of think about it being a little bit lower. And more isn't always better. When you have very high AMHs, greater than 3.5, greater than 4, we think about other things that might interrupt fertility. Things like polycystic ovarian syndrome, or PCOS, where there may be many, many eggs that the ovary is offering up to the brain, but the brain is having trouble picking one. And we know, even in the setting of IVF, you think, okay, more eggs that we might be able to grow in that group, that's got to be better, right? Turns out it isn't always, because sometimes when you get such a big group, we may jeopardize how those eggs develop and the capability that those eggs have to make it all the way to a baby. So there's some data that talk about quality in the setting of a very large group of eggs. So more isn't always better. There's probably a sweet spot for a number of eggs when it comes to IVF in particular. And then the last thing we can do is antral follicle count. So an antral follicle count is an ultrasound looking at these small follicles. These eggs, as they're just being offered up to the ovary, it's usually done in day 2 through 4, 2 through 5 of the menstrual cycle. And we want to see it on the higher side. So, ideally more than 10 is what we look for. So what is diminished ovarian reserve? This is a diagnosis that we do report as part of our IVF statistics. And we used to think that this was actually a cause of infertility, that this was a reason why people had trouble getting pregnant. We know actually it's no longer necessarily in and of itself a cause of infertility. Just having a low number of eggs doesn't really matter when somebody's trying to conceive without IVF, because you're releasing 1 egg at a time. Who cares how many eggs it's coming from? And there was actually a 2017 study published in the journal JAMA, a journal of the American Medical Association, a giant journal both in OB/GYN, but in medicine in general, that followed just shy of 800 cisgendered heterosexual couples, followed them prospectively, followed them moving forward after doing a bunch of the testing we just talked about. And it turns out that it didn't matter if you had a low number of eggs, a medium number of eggs, or a high number of eggs based on that testing. It didn't impact who was going to meet criteria for infertility and qualify for more treatment, and who was going to get pregnant without treatment. So, so it turns out egg number doesn't matter until we're talking about treatments that we can do to help get to a baby faster. So diminished ovarian reserve, we generally think of as a low number of eggs in the ovary. Unfortunately, there's not really a standard way of defining this. And you can see this is a chart from 2010 from the CDC, where we collect data from almost every IVF cycle done in the US. And you can see it's a significant portion of the population. And this was from 2010 because I liked the way they laid this out. But the numbers are very similar year to year. We haven't seen a significant change in the number of folks who meet this, who have this diagnosis, meet this criteria. The most recent criteria that people have moved towards using does sort of group people both by ovarian reserve testing, but also response to IVF, because it's the other way to be diagnosed with lower ovarian reserve, is we can have clues based on this testing. But if you've ever gone through IVF or known somebody who has, our testing is only so good. We learn about people's physiology, we learn about people's ovaries and how egg and sperm mix in the process of the treatment as well. So this grouping takes into account a response to IVF as another factor, which is nice. I think it's more comprehensive when we think about people. And it's not hugely important as to which group is which, but just to say, we do, when you see somebody like me for treatment, we do take into account both the initial testing that we do, that ovarian reserve testing, but also when you do, hopefully we guess right, and you have a successful IVF cycle, but especially when this testing might be on the lower side, or even if it isn't, we can be surprised and find out that maybe the ovaries don't respond the way we would expect, and we can make adjustments moving forward in the protocol or in the recipe that we use to try to coax the ovary to grow more than one egg in a cycle. And this is just to show, this is from that paper in 2017 from JAMA that showed that this diagnosis of diminished ovarian reserve, or just general number of eggs in the ovary in general, is not associated with infertility. So meaning this was, you can see this group of people, the different colors being higher ovarian reserve, middle of the road ovarian reserve, and low ovarian reserve. The probability of a pregnancy, a spontaneous pregnancy, a pregnancy achieved without any sort of medical treatment, there's no significant difference in the chances of that pregnancy occurring based on the total number of eggs in the ovary. And you can see this even over the course of a year, that it doesn't matter. It doesn't change, which is reassuring. Where it does matter is when we start to think about treatment. So how do we treat folks who are having trouble conceiving? And most of it relies on coaxing the ovary to grow more than one egg. And we can do that with oral medication to kind of trick the brain into thinking that the ovary has no eggs there. And so the brain makes a louder signal to the ovary to grow eggs. And these pills are usually taken at the start of the menstrual cycle, just as that new wave of eggs is being offered up. It can start on day 3, 4, or 5, and you usually take them for 5 days. So even when folks are ovulating on their own, this hopefully will get more than one egg to ovulate, to have more than one chance of egg and sperm to meet in an IVF cycle. And that can be paired with intercourse, if somebody's partnered with somebody with sperm, or an IUI in the setting of otherwise unexplained infertility, or where we don't have a great reason as to why somebody's had trouble conceiving, or if there's donor sperm involved. And then another way to coax the ovary to get more than one egg to grow and develop is actually with injectable medications, the same hormone the brain uses to talk to the ovary, follicle stimulating hormone, or FSH, growing follicles, growing eggs. We can use that medication at a low dose. And that's usually paired with an IUI, so concentrating sperm and putting it into the uterus to get more moving sperm closer to where they meet in the fallopian tube. If you remember that picture at the start, the sperm has a long way to go from the cervix all the way to the fallopian tube, kind of like an ultra marathon with a lot of obstacles in between. So if we can move up that starting line, sometimes that can be helpful. When we use injectable medications like FSH, we're not allowing the conversation between the brain and the ovary to kind of control how many follicles or how many eggs are developing. And so we have to watch really closely with transvaginal ultrasound and with blood work, because the risk with either of these options is that we're very successful in getting more than one egg to develop, and that can put the person who's trying to achieve a pregnancy, can put that person at risk for twins. Or sometimes, especially with the injectable medications, more than twins, which in my world we really don't like. We don't even really like twins. I mean, of course, when it goes well, it thankfully goes very well. But whenever there's more than one baby growing in a uterus, there's higher risk of all sorts of complications of pregnancy, high blood pressure in pregnancy, diabetes in pregnancy. So we try to avoid that in my world if we can. And then our sort of big guns of fertility treatment is in vitro fertilization, or IVF. We use the term IVF in two ways. One, about the process where we stimulate the ovaries, watch really closely as those ovaries are growing eggs, and then remove them from the body, mix them with sperm outside the body, and then usually put one embryo at a time inside the uterus if it's tested to be of good quality, have the right number of chromosomes, or if it's a young egg. As the age of the egg, we'll talk about in a minute, gets older, we do feel comfortable many times putting more than one embryo in, because we know the chance of that embryo making it all the way to a baby is lower. And this IVF process can be done with either somebody's own eggs, or it can be done with donor eggs, which is a great option as well. And we do it very similarly, as I said, to the ovulation induction with those injectable medications, but we use more. We take that knowledge of that wave of eggs that the ovary is offering up to the brain, and then we actually will make sure that the brain does not talk at all to the ovary. We shut down that conversation, and then we just yell at the ovary to try to get all of those follicles, all of those eggs to grow together. And we watch really closely with transvaginal ultrasound and blood work as those follicles develop. And then we actually have the person take the signal to ovulate, take a trigger injection to ripen the eggs and get them ready to be removed. And so it's an excellent tool to increase the odds every cycle. And we know that how the chance of success, how likely it is that somebody has a baby from an IVF cycle is highly age dependent, because that's really what we're talking about. It's the only test we have when we talk about egg quality. Age is that test. And we know this because the eggs that are ovulated later in life, they've been sitting there since before the person was born. And I think about it kind of like a library. If you go to the new section where brand new books are, the books are really easy to read, and all the material is very easy to interpret, easy to read. And then you go to the stack section of the library, and it's a bunch of older books. Some of the pages are falling out. Maybe somebody stuffed a book into another book, so it's harder to read. And when an egg has instructions that are hard to read, most of the time the embryo doesn't even form or doesn't develop, so it won't even implant and make a pregnancy. And if it does, there is a higher chance of miscarriage, which we'll talk about in just a minute, because depending on those instructions, what chromosomes are missing or there's extra of, sometimes, as we said, most of the time those chromosomes, those books of instructions to build a person, if there's the wrong number, the embryo won't even implant, won't even result in a pregnancy. But if it does, there's a higher chance that it makes it to a miscarriage. And we can see this by looking at this. If you look at the green circles on this chart, again, this one's from 2016, but it's the same chart every year, where the age of the egg really matters in terms of the chance of that egg making it all the way to a live birth. And that was the outcome in this chart, was a live birth. And then you can see, if you use a donor egg, an egg from somebody who's younger is the majority of the time, somebody who's under the age of 35, you can see that this sort of effect on the chance of a live birth is fixed, that it really is, everything's in the egg when it comes to those chances. And we see that, those chances start to decline more sharply at 35. But really, it's in the late 30s, 30 and above, that we see the sharpest change, and then into the 40s, such that there's really kind of less than a 5% chance of conceiving with your own eggs in IVF. You can see there's a little uptick at the end here, but that's because the number of people in this database who are over the age of 44 who are cycling is very, very low. So most of those people are going to be counseled away from IVF using their own eggs. So it's hard to kind of take that. You have to take it with a grain of salt. It's hard to really interpret that well. And then, as I talked about as well, and the increased risk of miscarriage also, excuse me, due to that wrong number of eggs, wrong number of chromosomes rather, in the egg. And again, you can start to see that go up a little bit as you move into the mid to late 30s. And it's really over the age of 38 that you see this sharpest change in the miscarriage risk. And thanks to testing of embryos, which you may have heard about pre-implantation genetic screening or pre-implantation genetic testing for aneuploidy, where we grow embryos to the stage where there's more than 100 cells, the blastocyst stage, day 5, 6, or 7. At that point, the embryos have some cells that are dedicated to become the baby, some cells that are dedicated to become the placenta. And we can biopsy a few of the cells that become the placenta, maybe 5 out of the more than 100 cells, and check to see, does that embryo have the right number of chromosomes, the right amount of DNA, the right number of books of instructions to build a person? Is it euploid? And what we can see in this study that had over 10,000 embryos that were biopsied, we can see again that just like those other charts where you see the miscarriage risk going up and the fertility, the chance of a live birth going down, we can see that that links to the number of embryos that are aneuploid, that have the wrong number of chromosomes. And you can see that inflection, the kind of slopes start to kind of creep up at around 35. But really, again, the sharpest changes are happening in the late 30s into the 40s. So age matters when it comes to quality. And the major driver is age, as I said. You notice we haven't talked about anything else, just age right now when it comes to quality. So keep that in mind as we talk later about supplements. Different treatment strategies within IVF. How do we coax that ovary to grow as many eggs as we can in an IVF cycle to have every chance for egg and sperm to meet, especially when that pool of eggs that the ovary is offering up to the brain is low in the setting of diminished ovarian reserve? Well, one of the ways to do it is just the regular way we stimulate, conventional stimulation, where we really do yell at the ovary. We use high doses of FSH and sometimes FSH and LH, Follistim, Gonal-F, Menopur, to get as many eggs in that group of eggs to grow. And there's a lot of different versions as to how that looks. We have an estradiol patch protocol where we do that before your period even begins, and then we use doses of the high doses of the medication and then block the signal to ovulate. There's the microflare or microdose Lupron flare protocol, where we use tiny doses of Lupron, something that kind of asks your brain to give a little bit more FSH and LH to stimulate the ovary and grow eggs. And then we at the Brigham have even a different protocol where we kind of gently quiet the ovary and sort of take over before a period actually begins, using a more concentrated but still low dose version of Lupron. So there's all to say, it doesn't really matter, but there's many ways to strategize surrounding how to get that ovary to grow as many eggs as possible, to have as many chances of egg and sperm to meet, and chances at pregnancy as we can. And unfortunately, there's not a ton of markers to say which one is best to start with. So again, this is part of that learning process. When people go through IVF with their own eggs, we can learn from how the body responds and then make changes to improve things moving forward. And then there's this other strategy that has gone kind of in and out of vogue and more recently come back into vogue, minimal stimulation. And what we do is we use one of those oral medications. Most commonly, it's clomiphene citrate or Clomid. And then we use kind of a medium dose, a lower medium dose of the injectable medications to get probably fewer on average, oftentimes similar, but sometimes fewer on average eggs. But the thought is that maybe they might be a little bit better quality because we're using that conversation between the brain and the ovary a little bit more. So hopefully we're recruiting eggs that have a better chance of making it all the way to a baby. In the study setting, it really, when it's been studied, the chance of live birth is very similar. It doesn't seem to be hugely different, but there's, as anybody who's gone through fertility treatments knows, there's a lot of variability from person to person. So, so definitely the theory might be true. And then, and then there's another strategy to do this IVF process, but with eggs from someone else, donor eggs. And this is, of course, a very different road to go down for many folks. And there's many roads that can lead to donor egg. One of them might be a road that somebody knew off the bat. Maybe they don't have eggs of their own, or potentially they've run out of eggs before they've been ready to childbear, premature ovarian insufficiency. So it may not be a surprise that this might be an option, but for many folks who use donor egg, it's something that is an option after they've been along a road trying to conceive with their own eggs. And they found that trying to coax the ovary to grow eggs from that small pool really hasn't been successful. And so, as we had looked at before, the age of the egg really does matter in terms of chance of success. So sometimes when somebody is ready to family build or ready to add additional members to their family and they're older, especially over the age of 44, so it may not even be a conversation to have them to use their own eggs. It may be, depending on the provider that they go see and their ovarian reserve testing, it may be that we go right to donor egg, then it makes the most sense. So again, many roads that may lead to egg donation. Any way you slice it, it's a very effective way of building a family, though a different way than many envision. And the hope is, especially when you put an egg donor, whether it's somebody you know or don't know, when you put that egg donor through an IVF process, the hope is that one, you get more eggs. And usually the donor has been screened either by the clinic that you're using, or if there's somebody who's unknown at an agency. The hope is too that you're getting more eggs. So that would be the goal, that you have more options by putting somebody through a cycle. And I've been talking about having somebody who's a fresh donor, meaning you're the person who is the intended parent, the person who is family building, has picked this donor and put that person through a new IVF process to pair with a sperm, oftentimes from a partner or another donor as well. But the other option is to use an egg bank, where these companies, egg banks, have egg donors that cycle totally separately from this person who's currently family building at this moment. And then they divide that cohort of eggs up from that fresh cycle into groups of 6 to 8 eggs and sell them as cohorts, as kind of groups, bunches of 6 to 8 eggs, with the hope of having 1 or 2 chances at pregnancy. So there's what's called a blastocyst guarantee, that usually from one group of eggs, you have 1 shot at pregnancy that is a little bit less usually than a 50-50 shot at pregnancy. So it's nice because it's really, for many, it's kind of like shopping, that it's really removed from the person and you're just sort of buying these eggs. It is cheaper per group of eggs. Tending to run between $16,000 and $18,000 for the eggs themselves, versus if you didn't know somebody, an anonymous or unknown egg donor with a fresh cycle, that runs in the range of $30,000 to $40,000 with the agency fees. So it's significantly cheaper for that group, but also you're getting fewer options for pregnancy. And additionally, the embryos that are created from fresh eggs seem to have a slightly higher chance at a live birth than those from frozen eggs. That if eggs that are frozen it's a very good technology and they do very well. That's why it's offered. But it's not perfect. The eggs are the largest cell in the body, and it's a big stressor to freeze and thaw them. And so that potentially is the reason why maybe those success rates are slightly lower. Still very high compared to using non-donor eggs in the setting of infertility. And again, fresh cycles where you get many eggs and hopefully many embryos may ultimately be less expensive if somebody's trying to build their family with more than one child, an option for not just the first child, but future children. So it's all a conversation with the clinic that you're seeing if this is a road that you're interested in pursuing or your doctor brings up as a road to consider. And as I mentioned, you can have a known or unknown egg donor. I use the terms known or unknown, and I kind of steer away from anonymous because in this day and age of 23andMe and Ancestry.com, I don't know that we can ever say anybody's anonymous anymore, but known or unknown, and using somebody that you know in your life to be a donor is a unique relationship with that person. So not everybody has somebody in their lives where that's an option. But if you do, it does significantly reduce the cost because those agency fees aren't there. You just need the screening of that donor to make sure you do what we can to ensure that this person is a good candidate for IVF. Because remember, as we talked about, fertility and IVF response are two totally different things when you're trying to conceive without IVF or you're trying to conceive with IVF. Also, one of the perks of being in Massachusetts in particular, for those of you that are, and some of the policies in other states too, thankfully you're catching up, due in large part by the work with our Resolve New England amazing team, the colleagues in that organization and the advocacy that they've done. There are portions of the egg donation process that might be covered. So oftentimes the cycle itself, the cost of a cycle, which can run, $15,000 to $20,000, that often can be covered, and that's separate from the agency fees, right? The cost of stimulating the ovaries might be covered by insurance if somebody has failed multiple IVF cycles. A lot of the major insurers, it's 3 IVF cycles where the person has had a very low response or diminished ovarian reserve response, and their age is oftentimes less than 40. Some people it's less than 42. So it depends on the policy. So there can be significant insurance coverage to defer some of the costs associated with egg donation. And then just to kind of round out the conversation, are there supplements that can help with egg quality? Remember, we talked about age being the major driver of egg quality, the major driver of those books of instructions within the egg to build a person. But of course, there's more to an egg than the instructions, even though that, of course, is the major driver. There's a thought that maybe there's something we can do to tweak the machinery of the egg. How it looks under the microscope and how it behaves once it meets with sperm. And so, unfortunately, there's a lot of supplements out there that are marketed because, understandably, I think there's a lot of people thinking about things that might make a difference. But there's really very limited studies that show benefit. There's a lot of studies out there, but not many that are well designed rather, and also well defined surrounding how they actually do benefit egg quality and ultimately the chance of a baby. Coenzyme Q10 is probably one of those that has the most data, and it's really for egg quality, not changing the number of eggs, but how each egg behaves. And as I said, unfortunately in humans, not a clear benefit. But this came to market based on mice modeling. So there was a big study published in a big journal back in 2015. And what it did was it gave mice coenzyme Q10 compared to a placebo. And it showed that the mice that were on the CoQ10 for 12 weeks, so 3 months, that sounds reasonable, improved the chance of conception overall compared to a bunch of other supplements, anti-aging supplements, and also a placebo. So, and so this seemed great. We were like, oh, great, we'll give humans CoQ10 for three months. That seems totally doable. Unfortunately, then study after study has shown no clear benefit in terms of increasing pregnancy rate or live birth. Some of them have showed maybe the eggs look a little bit better under the microscope. Maybe they look better as embryos, but not really a difference in the outcome that really matters. And probably, some of the limitation of this is because the studies were variable in how they were designed and the dose they used. You can see the dosing of CoQ10 ranged immensely from 600 to 1200. I usually tell people 600 is probably enough. And some of them didn't even give the full 3 months. But even those that did, probably some of the reason we haven't seen the benefit that they saw in the mice is because 12 weeks of mouse time is 10 years of human time. So it's really hard to get a decade of antioxidant on board before we put somebody through IVF. So that's probably why. But for a lot of my patients, I say there's no downside other than the cost of the supplement. So why not? So I do tend to recommend this. The other supplement that has some data, it's more controversial and actually has some side effects, is DHEA. This is an adrenal hormone, so not to be confused with DHA, which is a totally different, really good for heart and brain health DHA that's in a lot of prenatals. This is DHEA, coming from the adrenal gland is where it originates when it's inside the body. And we know these numbers tend to go down with age. And we know that this adrenal hormone is important as an ingredient for the ovary to make estrogen, which, remember, comes from the follicles. So the thought is maybe if the adrenal gland isn't making enough of these, this hormone, maybe that's the reason why the follicle pool, the group of eggs, is shrinking. It just doesn't have, the ovary doesn't have the ingredients that it needs to grow those follicles. So it just makes fewer of them. That's the thought. And so smaller studies that were very little showed that there might be a benefit in people with lower ovarian reserve, but the results were really mixed. And it does seem like higher levels of this hormone can actually interrupt how we can measure other hormones that are really important when we're doing IVF or we're doing monitoring of cycles in general. So we do watch progesterone levels really closely in an IVF cycle, and we won't put an embryo into a uterus if the progesterone level goes up too soon. And so if people are on really high levels of this supplement, it may look like they couldn't do it in embryo transfer, when in reality it would have been fine. So maybe too much of DHEAS might be a bad thing. And there can be side effects. So you can get oily skin, acne. So for folks that are prone to that anyway, it can be really uncomfortable. And the process of IVF is tough, on the body as it is, or it can be. And so adding to that with a supplement that might have benefit, but it seems like really maybe doesn't, it feels like a lot. So I would really kind of talk to your own individual doctor about how they think about this supplement. And just in the last minute or so, there are a lot of experimental therapies out there. I would say these are not recommended. And the American Society of Reproductive Medicine, ASRM, came out and really made a statement about this to say, there's a lot more research that needs to be done before engaging in these very expensive and highly experimental medications. That lack of studies supporting the use of something isn't the proof that it works, or the proof that it's safe and it doesn't have downsides. So it's really something to consider. Human growth hormone was one of the ones that has the most promising theory behind it, and very small potential studies might be helpful. But again, so far from being ready for prime time, high doses of human growth hormone have been linked to the development of cancer. It's very, very expensive. And actually, in folks who have insulin resistance or even diabetes or prediabetes, this can kind of boost up blood sugar, which actually can be detrimental to pregnancy outcomes. So definitely something to be wary of. Platelet-rich plasma is the other one that is being offered by some clinics. And again, I think it has the potential to be very helpful. There's different theories about where to inject it, into the ovary, into the uterus, and how it might work. But there's really been no well-designed studies to show benefit of this. Very limited data in small study setting, and it's very expensive. So taking it all very much with a grain of salt in this setting. So in general, remember, all people with ovaries are born with all the eggs they're going to have, and the number and quality decline over time. They tend to do it tracking together, but for some individuals that the quantity may drop before the quality does, because again, quantity does not equal quality. They're separate. Age affects fertility, and it also separately affects IVF outcomes, both because of that quantity and quality, because remember, age is the measure of egg quality, the major driver. And we talked about those ovarian reserve tests that you can do, the 2 in the blood and the 1 on ultrasound. Diminished ovarian reserve, that title, that diagnosis, means just generally fewer eggs. This may be fewer than we expected based on age, or it may be part of the usual aging process. So it might be something very normal, especially as people move into their late 30s and early 40s. And we talked about those treatment strategies to stimulate somebody's own ovary, and then also using donor egg as a great option, though again, a very different road. And then supplements, definitely to connect with your doctor about, with the most data being behind the CoQ10 and the DHEA. And then the PRP platelet plasma and the human growth hormone, very experimental. And we as a field do not recommend them at this time. So thank you so much. I put Kate's name up here, but Emily Lindblad too at Resolve New England. And then, of course, all my colleagues at Brigham Fertility Center for Infertility and Reproductive Surgery. And of course, my more junior colleagues, the fabulous fellows that we work with, and my nursing team, and my managed care, the finance team navigating the financial world of thankful insurance coverage. It does take a village to help people family build. So this is my village. So thank you so much. And please do follow us, both me and our group on Instagram. And of course, I am happy to take more questions. Happy to take any of those questions in the chat.